Very good afternoon. My name is Dr. Vivek Varkad. I am from India, LV Prasad Eye Institute, Bhubaneswar. So I welcome you all, in today's symposium on myopia and its complication. So without much delay, we'll start this session. And the most interesting part of this session is we are going to learn today, the all aspects, particularly the complications in a different subspecialty we do come across in our day-to-day practice in patients with the high myopia, or for that matter, the progressive myopia. So I would like to invite all the speakers of this session. So Dr. Keto Matsui, she is already here from Japan. Then I would like to call Dr. Josh B. Jonas. Please come on the dais. Then we do have another speaker, Dr. Tomonari Takahashi. Please come. Please take a seat. Then Dr. Timothy Lai. And then Dr. Suen Lee. Please come. So we will start the session with the first talk by Dr. Kyoto Matsui from Japan. She is going to talk about, the cutting-edge imaging technologies for pathologic myopia. Over to you.
Thank you very much, Vivek, for a kind introduction. Where is my slide? Excuse me, where is my slide? I don't see. I uploaded, but I don't see mine.
You have it on a pen drive by any chance? You uploaded in the preview?
Yes. Project Hall or the next speaker?
Yeah, I think call the next speaker and call the next speaker.
Yeah, I think there is some technical glitch. By the time, Dr. Matsui will make her presentation ready, I would like to call Dr. Josh B. Jonas to deliver his talk on complication and benefits of myopia.
Dear Chairman, ladies and gentlemen, it's a great honor and pleasure for us to be here. Studies have shown that myopic macular degeneration has become one of the most common causes for irreversible visual impairment and blindness. For example, in the Beijing Eye study performed 10 years ago, or 15 years ago, it was the most common cause for irreversible impairment. That was the reason that we looked at the risks and potential benefits of myopia, because in some studies it appeared that at least moderate myopia not only had disadvantages but advantages. For that purpose, we looked into the data of the Beijing Eye study performed in 2011 on about 3,500 participants with an age of 50 plus years. We looked at the data of the Central India Eye and Medical Study performed in a rural region in Maharashtra on almost 5,000 individuals with an age of 30 plus years. We looked into the data of the Ural Eye and Medical Study performed between 2015 and 2017 in the Republic of Bashkortostan in Russia at the southern end of the Ural Mountains on almost 6,000 participants with an age of 40 plus years. And into the data of the Ural Variole study, which was conducted in the same region on 1,000 individuals with an age of 85 years or older. It appeared that, for example, in the Ural Eye and Medical Study, moderate and high myopia was protective against diabetic retinopathy, against age-related macular degeneration. It was associated with a lower prevalence of angle closure glaucoma, and if it was moderate, myopia was associated with a slight increase in the prevalence of open angle glaucoma and with a marked increase in the case of high myopia. Similar findings were found for the Central India Eye and Medical Study, with a potentially protective effect of myopia against diabetic retinopathy, AMD, and angle closure glaucoma, and an increase in the prevalence of open-angle glaucoma, particularly in the highly myopic group. And also in the Beijing Eye study, similar results were found. In the Beijing Eye study, which was conducted longitudinally between 2001 and 2011, it also appeared that, for example, the 10-year incidence of diabetic retinopathy was lower in myopic eyes. The same was found for the 5-year incidence of age-related macular degeneration. And as said before, the 10-year incidence of open-angle glaucoma increased. So that the question was, if indeed myopia is protective against AMD and diabetic retinopathy, what might be the reasons for it? And if one goes to small-scale clinical studies, they suggested that the intraocular concentration of VEGF decreased in eyes with longer axial length, potentially due to a larger intraocular volume leading to a higher dilution of the molecule, and perhaps also to a higher and faster turnover of the molecule because the viscosity of the vitreous is less. Then the question was, if moderate myopia may be perhaps considered a bit like a benign type of myopia, then the problem clinically is high myopia and where may be the cutoff. If one goes for the enlargement of parapapillary zones or enlargement of the disc, the cutoff may be somewhere at -6 to -8 diopters of refractive error, or an axial length of 26 or 26.5 millimeters or more. Beyond that cutoff, for example, the prevalence of glaucomatous or glaucoma-like optic neuropathy increased markedly, as shown in this Tokyo study. However, with the caveat that also it was glaucoma, there was not yet shown an association with intraocular pressure. So that at the bottom line, going for these risks of myopia, particularly of high myopia, this glaucomatous or glaucoma-like appearance of the optic nerve markedly increases with high myopia. It may be called glaucomatous if the IOP is elevated. It may be called glaucoma-like if the IOP is normal. As also shown in these two examples, where the kinking of the blood vessels close to the optic disc suggests an almost complete loss of the neurogenal rim. And in the Tokyo study, a larger parapapillary delta zone or a larger optic disc were the factors associated with the higher prevalence of this glaucoma-like optic neuropathy. Finally, in addition to the glaucoma or glaucoma-like optic neuropathy, there's a non-glaucomatous optic nerve damage in highly myopic eyes, the prevalence of which also increases markedly for the highly myopic group, can go up to 80% in the extremely myopic group. Correspondingly, the nerve fiber layer thickness decreases. And the reasons for this non-glaucomatous optic nerve damage may be just the elongation of the eye, leading to a longer distance between the ganglion cells and the optic disc, leading to a lengthening and potentially stretching of the optic nerve fibers, which may lead to a damage. The same may be the case for foveal ganglion cells and their axons, if gamma zone developed, leading to an elongation of the disc fovea distance in a ratio of 1:1, and potentially to a stretching, elongation, and damage of the fibers. So that is conclusion. Axial myopia may be partially protective against diabetic retinopathy, AMD, and angle closure glaucoma, and it may be wonderful as a functional compensation of presbyopia. It is not too high. Problematic is high myopia, with of course the risk of myopic macular degeneration, then the glaucomatous and glaucoma-like optic neuropathy and non-glaucomatous optic neuropathies, for which the associated or risk factors were a longer axial length, a larger parapapillary gamma zone, and for the glaucoma-like optic neuropathy, a large optic disc or a large delta zone. Thank you very much.
Thank you, Dr. Jonas. Thank you, Dr. Jonas, for a very wonderful talk. So, is there any question from audience? Oh, you have?
Yeah.
Yeah.
Just wonderful talk as always. Thank you so much. So myopia is protective against diabetic retinopathy and AMD. So some people say myopia is bad and all myopia should be eliminated, but at least they have some good things. So overall, glaucoma do you think is the worst complication in myopia, because it progresses in parallel with the myopia increase, and also no cure, no recovery for glaucoma?
I'm not aware of a study which has already conclusively compared the vision impairment in highly myopic eyes due to glaucoma or optic neuropathy compared to macular degeneration. Often they also concur simultaneously. Therapy at the moment is not yet possible, at least not on an evidence base. If one has a glaucoma-like optic neuropathy, one may consider lowering the IOP, even if it is in the normal range. But studies have started to look at it in a randomized manner.
Yes, please.
Josh, fabulous talk, thank you. May I know what's the case definition of glaucoma in a high myope? Because 20 years ago has shown that more than half of the patients with more than 10 diopter would have field loss of some form. Do you require field drop, as in GPA progression, to label it as high myope, or do you have typical glaucoma field loss according to the usual glaucoma case definition? You call it glaucoma in high myope.
In these studies which we conducted, we did not use visual field parameters for the definition. It was mostly the appearance of the optic nerve head. That means if the neutral rim shape, also in the highly myopic, abnormally shaped optic disc, was not fulfilled, particularly if there was a border kinking of the vessels close to the optic disc border, inferiorly and superiorly, then we called it glaucomatous or glaucoma-like. And also clinically, these patients tend to have sometimes quite constrictive visual field constriction.
Thank you, Dr. Jonas, for wonderful inputs. So the next speaker is Dr. Kyoto Matsui from Japan. She's going to talk about cutting-edge imaging technologies for pathologic myopia. You can go that side. You can please go. You can go that side.
Okay,
Yeah.
thank you.
Yeah.
And
Please go that side. That podium.
Oh, that
Please,
podium.
yeah,
Oh, okay. Okay. Thank you very much for your kind introduction again. And in pathologic myopia, a wide area of the fundus is affected, making it more than just a macular disease. In this image, a wide staphyloma, along with extensive peripheral degeneration, is clearly visible. Therefore, wide field imaging is extremely useful for visualizing these fundus abnormalities. For this purpose, I have been using the Canon Zefilio since its prototype stage. And these days, thanks to Jamie Choon's tremendous support, we have had the privilege of using this incredible Trim OCT. So using these two devices, today I'd like to discuss the wide field OCT findings of posterior staphyloma and myopic traction maculopathy. First, staphyloma. Posterior staphyloma is an outpouching of the wall of the eye, and it's usually is underlying cause of myopic fundus complications. In the Optos image, the upper edge of staphyloma is seen. In B-scan or wide field OCT, the staphylomatous region shows a posterior displacement of the sclera. For the detection of staphyloma, identifying their edges is important. Staphyloma edge shows consistent features with gradual thinning of the choroid from the periphery toward the staphyloma edge and a gradual rethickening toward the posterior pole. And 3D OCT movie clearly visualizes the entire shape of staphyloma. A spatial relationship between staphyloma and the optic disc macular and retinal vessels is clearly seen. This facilitates the understanding how visually important tissues are damaged by staphyloma. And wide field OCT is suitable for use in children, allowing us to determine when and how staphyloma develops. The study shows that staphylomas develop at a much younger age than previously thought. And this is an 8-year-old girl with axial length of 26 millimeters. At baseline, the inner scleral curvature is inclined toward the optic nerve, and no staphyloma edge is seen. 3 years later, the axial length has increased by 1 millimeter. Scleral inward protrusion, suggesting a staphyloма edge, is formed nasal to the optic disc. The macular sclera bows more posteriorly, and now the fovea is located in the deepest point of the eye curvature. In children and adolescents, staphylomas edges tend to occur around the optic disc. And this is an 11-year-old girl. At baseline, mild staphylomas edge is already seen nasal to the optic disc. And 4 years later, although the axial length has only increased by 0.2 millimeters, the eye curvature has undergone significant changes. In addition to the pre-existing edge nasal to the optic disc, a new edge has formed temporal to the optic disc. Concurrently, the sclera has bowed more posteriorly, with its deepest point temporal to the fovea, causing the fovea to shift nasally along the slope. This foveal displacement on the slope may explain the limited increase in axial length. These findings suggest that wide-field OCT can effectively differentiate children with pathologic myopia from those with physiologic myopia. Among the complications associated with staphyloma, myopic traction maculopathy is the most appropriate condition to demonstrate the relationship between the extent of the lesions and the staphyloma. In this patient, this is staphyloma edge. As you can see, inner and outer retinoschisis is restricted to the staphylomatous areas. In eyes with staphylomas, the retinoschisis does not usually go beyond the staphyloma edge. However, staphyloma may not be the primary cause of retinoschisis. To identify the underlying cause, multiple scans may be necessary, even with the use of wide-field OCT. For example, in this patient with macular retinoschisis, a horizontal OCT image reveals the edge of staphyloma here, and retinoschisis is confined within the staphylomatous area. The posterior vitreous is detached from the inner retinal surface within the staphyloma, but vitreous adhesion to the fovea is also seen. So based solely on this image, one might conclude that the retinoschisis of this patient is caused by foveal traction. But however, an adjacent OCT image shows that the 3 retinal vessels are lifted. Outer retinoschisis is more severe around these vessels compared to the foveal area. And inner and middle schisis are also seen around the vessels. And our oblique OCT section shows that the posterior vitreous adheres to the inner retinal surface at the site of these vessels. Multi-layered schisis is observed around the retinal vessels, while with the outer schisis extending from the area around the vessels toward the fovea. Such vascular traction may not be apparent on conventional 6 mm scans or even cross-sectional scans with wide-field OCT. However, radial scans using wide-field OCT can effectively identify vitreous traction on retinal vessels. In this case with retinoschisis, the posterior vitreous is thickened, and there is a single vertical strand connecting the posterior vitreous to our retinal vessels. Outer retinoschisis is prominent around the vessel. And in this 3D movie, you can see numerous strands connecting the posterior vitreous surface and retinal vessels. This image shows how strong the vitreous adhesion to retinal vessels is in pathologic myopia, especially with retinoschisis. And Takahashi and colleagues compared highly myopic eyes with and without macular retinoschisis and found vitreous adhesions to retinal vessels more frequently in eyes with retinoschisis. In contrast, adhesions to the fovea did not significantly differ between groups. Paravascular lesions such as paravascular cysts, retinoschisis, and paravascular lamellar holes were more common in eyes with retinoschisis. Multivariate analysis identified paravascular vitreous adhesions as a significant predictor for development of retinoschisis. Here I'm presenting cases that highlight the significance of vascular traction in traction maculopathy, and the images were taken with the DREAM OCT. In the horizontal scan of this case, retinal schisis is observed both around the macula and nasal to the optic nerve. But in the vertical scan, multiple retinal vessels protrude, and retinal schisis is more pronounced around the retinal vessels. Paravascular abnormalities such as retinal cysts and retinal thinning are also observed around the vessels. An ANFAS OCT imaging of this patient reveals straightening of retinal arteries and a separation between retinal veins and arteries. Likely due to these changes, numerous paravascular retinal cysts are observed along the upper and lower case. And this is another case. You can see our retinal vessels are lifted, and retinal schisis is more pronounced around the retinal vessels. And previously, although we used 6 millimeter scans at that time, Shimada reported that paravascular lamellar holes were found in as many as 83% of eyes with retinal schisis, with the outer schisis extending from around the retinal vessels to the macula. This also highlights the significance of traction of the retinal vessels. While retinal schisis is a macular lesion, its origin may lie away from the macula, often around the retinal vessels. Like this one. Yes. And it carries, some people was in favor of macular buckling, but macular buckling surgery does not address the root cause of myopic structural maculopathy, which lies in vascular traction outside the macula. So we know, with these days, we just peel IOM around the retinal vessels, and retinal schisis gradually recovers. So identifying the root cause using radial scans or wide field OCT and treat minimized treatment would be better, because many patients also have glaucoma. So in summary, ultra wide field OCT is a powerful tool to visualize the entire extent of traction maculopathy. Wide field OCT clearly shows a relationship between staphylomas, retinal complications, and vitreoretinal adhesions. And traction maculopathy may originate from an area away from the macula. Releasing the vitreous traction to retinal vessels is important to cure this disease. So thank you very much for your attention.
Thank you so much, Dr. Matsui. I think we are coming out with something, the great learning that probably we need to use wide field OCT to really understand, the structural anomaly in patients with these. And if there is a quick question we can take, otherwise, the next speaker, Dr. Takahashi, he is going to talk about, how to deal the tractional, the maculopathy. So if there is a one question we can take, otherwise we'll have a question after his talk.
Okay, so hello, I'm Tomonari Takahashi from the Institute of Science Tokyo. It's my honor to have presentation here. Okay, so today I'm going to talk about how to manage myopic traction maculopathy. Okay. So first of all, myopic traction maculopathy, MTM, is a schisis-like thickening of the retina in eyes with high myopia. It is estimated to affect 9 to 34% of highly myopic eyes with posterior staphyloma. Pars plana vitrectomy is useful for resolving it. OCT is the key instrument to diagnose MTM. The key factor of MTM is tractional forces. So MTM is an umbrella term that includes several conditions. It includes lamellar or full thickness macular hole and foveal detachment. Normally, retinal schisis and lamellar macular hole is stable, but in some cases, the condition could get worse, and foveal retinal detachment and full thickness macular hole could happen. For those cases, we should do PPV for preventing the aggravation. So what is the tractional forces? There are some reports about it. In general, 5 types of tractional forces could be considered: vitreomacular traction, vitreous cortex, retinal vessels, internal limiting membrane, posterior staphyloma. Mild factor of these could make the MTM condition. So we should talk about vitreous liquefaction and PVD. The prevalence rate of PVD is 43.2% in high myopia, which is 5 times higher than in ametropic eyes. In high myopia patients, the prevalence of complete PVD is overestimated because the posterior cortex may still be attached to the retina despite clear visualization of vice link. The presence of remnants in 6.7% of non-high myopia and 37.7% of high myopia patients. Internal limiting membrane, ILM, is considered to be a main cause of traction. ILM is the basement membrane at the vitreoretinal interface, and it is considered of type 4 collagen, laminin, and fibronectin. ILM is thicker in the fovea than in optic disc and peripheral area. The rigidity increases with age. So how can we decrease the tractional forces? Vitrectomy with ILM peeling has been shown to result in anatomic resolution of MTM and to improve visual acuity, even without the use of gas tamponade. ILM peeling is effective, but complication like post-operative macular hole is a big problem. During the surgery, it is stained with indocyanine gleam or beryllium brucine. Downfall, the dissociated optic nerve fiber layer, is well-known complications after the surgery. It is most Eaton-like appearance like this picture that causes retinal sensitivity loss and palacentral scotoma. Next, I'm going to talk about how to diagnose MTM. OCT is the key to diagnose MTM. Just only for diagnosing it, normal OCT is enough. 9 by 12 millimeter is the maximum range in the normal OCT. But the ultra-wide OCT could get the image of 23 by 23 millimeter. When we do vitreoretinal surgery, ultra-wide OCT is better because we could detect tiny traction and peripheral retinal vessel adhesion. Please look at these pictures. The left pictures are the ultra-wide field OCT, and the right pictures are the normal OCT image. So in the ultra-wide field OCT image, we could detect the paravascular traction and how far is the retinal schisis is. So we could completely get the information at a glance. So this is one of the difference examination, retromode imaging. It is a pseudo three-dimensional image captured with a scanning laser ophthalmoscope, which uses 719 nanometer light with a deviated aperture instead of a central aperture. Retromode imaging is useful for detecting MTM because MTM is a three-dimensional disease. Up till now, we already know that two patterns of retromode imaging, striae and fingerprint. These two findings are both consistent with retinal schisis. First, macular striae. Macular striae is the linear lines that run radially from the macula, like this. And second, dots. Dots are granular findings near the macula. These dots does not exist in the center of the fovea, just near the fovea. The third, fingerprints. Fingerprints are consisting of dots and striae that have no fixed direction. Fourth, paravascular striae. The right OCT images is ultra-wide field OCT that could get more information about the peripheral area like vitreous traction and retinal vessel location. Paravascular striae is the straight line crossing the retinal vessels. We have searched total of 56 eyes of MTM. We checked the OCT images compared with retromode findings. There were no significant difference between the retinal schisis type and retromode image findings. The retromode findings does not simply show the schisis structure. However, retromode findings, especially the difference of macular striae and dots near the macula, could be the great implication for surgical intervention. The difference of two could be occurred due to the Henle fibers running. As for surgery, there is a big complication, post-operative macular hole. In 2012, Dr. Ho and Dr. Shimada invented fovea-sparing island peeling FSIP. Recently, FSIP technique is widely used for the MTM surgeries. There are some reports about efficacy of FSIP. The results are various. Most of the studies follow just 1 year. We did new studies that followed for 5 years. One big complication that should be considered is post-operative macular atrophy that is first reported by Fan et al. And different from macular neovascularization-related macular atrophy. The severe foveal condition before surgery have a higher risk of it. We have searched 31 eyes of FCIP group and 40 eyes of total peeling, standard ILM peeling group. There are no big differences in postoperative visual acuity and the occurrence of postoperative macular atrophy and macular hole. The summary is, there were no statistical differences. However, if the results do not change, there is no need to peel more than necessary. Island peeling could occur downfall and retinal sensitivity loss. We should choose FCIP than total island peeling. So, summary, how to treat MTM. As for examination, ultra-wide field OCT and retromode imaging are better for use because we could get more information. As for surgery, we should do with foveal sparing technique. As for follow-up, we should care about postoperative macular hole and atrophy. And totally, we should make a clear criteria for MTM surgery. Thank you.
Tomonari, great talk. Are there any questions from the audience, from the floor? Yeah, Timothy, please.
Great talk. Thank you very much. Do you use gas for these cases? Do you inject like long-acting gas or air, or just leave it with BSS after the MTM surgery?
Thank you so much. So this is a very nice question. Most of the cases, we do not inject tamponade, like air or SF6 and C3F8. But in some cases, like severe myopic traction maculopathy, and for those cases, we should take care about the palavascular abnormalities and palavascular hole after the surgery. So in those cases, we should do the air tamponade. Normally, we do not use SF6 and C3F8.
Yeah, please.
In a situation of a clear vitreomacular traction, would you recommend to remove only the vitreous or also the inner limiting membrane?
Thank you. Only with the vitreomacular traction cases, it is very difficult to treat, to peel the vitreous, because that's why vitreomacular traction is existed. So for those cases, the peeling with internal limiting membrane with vitreous macular traction is effective and safe, I think. This is my opinion.
Yeah, I just wanted to ask, maybe, Dr. Matsui or Dr. Takahashi, this is regarding, how do you identify the retinochisis in a very high pathological myopia is primarily because of the myopia or, the optic disc pit?
Yeah, are you asking whether the retinochisis is coming from optic pist or myopia? Yeah. Actually, yes. We don't see many optic disc pits in highly myopic eyes, but there is a condition like intrachoroidal cavitation, which is a fluid space within the choroid, usually lower to the optic nerve. And this ICC intrachoroidal cavitation can connect with the vitreous space and then finally to subretinal space. So retinal schisis can occur with this parapapillary lesion. But in that case, the distribution of retinal schisis is more severe near the optic nerve, so the distribution is a little different. Yeah, we think that, but with the radial scans, we identify where the retinal schisis is the highest, because in the highest area, almost always the causes are there.
Thank you.
Yeah. Okay, thank you very much. And I'm going to introduce our next speaker, who is my co-moderator, Dr. Vivek Warkard. He is going to talk about pharmacological management of myopia progression.
Shall I come that side or?
Recording now.
Oh, is it recording? Oh, yeah, we will play recorded videos at the end. So could you? Yeah. No, Vivek's one.
So, very good afternoon. So basically, I am going to take you through, the pharmacological management of myopia progression. I do not have any financial disclosures. So if you look at this slide, probably 5 to 6 years ago in India, before pre-COVID era, probably we were in a confusion. But I'm sure all of we are no more in a state where we do have confusion how to treat the myopia or a myopia progression. We do have very much the defined criteria to understand the qualitative or the quantitative definitions of myopia. So if you look at this, why the entire world is looking after the myopia and its progression is all about almost 50% of the children would be going to be myopic by 2050, as per the the Holden and group's prediction. So if you look at what does we have for the use and efficacy of atropine in myopia progression, probably yes, we do have a standard of care that we have learned from these landmark studies like ATOM 1, ATOM 2, and also recently the LAMP trial. So basically, if you look at those studies, they do have a population where the East Asian ethnicities being the majority of the cohort. But what do we have studies done in Indian population? Yes, we do have. You can see the various researchers. Dr. Rohit is sitting here. So we do have our own evidence. How does the atropine 0.01% do work in Indian population? So coming at to the treatment aspect. So WSPS myopia consensus statement has shown that what appears to work and what probably doesn't work, or we should focus more on what appears to work, and that we do have the behavioral interventions or a lifestyle modification, optical treatment, and also the pharmacological treatment. So I'll take you to a pharmacological treatment in my today's talk. So I'll talk more about the low dose atropine, which is most commonly used method for myopia control in today's world. And if you look at the data from these 3 landmark trials, I think we are pretty much now understanding what is the mechanism of action, how does it stimulates the extracellular matrix by this scleral fibroblast, and that helps to arrest the axial elongation. So it is commercially available as 0.01% drop, which is found to be effective in Indian population, although we don't have 0.05%, we are awaiting for that. So how does it work? So basically it releases the dopamine, which inhibits the retinal signaling pathway or a process, and that's how it inhibits the axial length elongation. There is another mechanism which reduces the ECM biosynthesis at choroidal level, increase the choroidal perfusion, thereby thickness, and thus the the axial elongation. But we need to aware about the fact that atropine does not act through the accommodation change, and it also does not work on a muscarinic receptor. So once you understand this, I think if you dissect these 2 studies, ATOM 1 and ATOM 2, apart from the concentration, 1% versus 0.5, 0.1 and 0.01, so I think 77% reduction in myopia progression, if you look at the, so quite effective, right? But it do have its own side effects like blurring of vision, photophobia, or increased ultraviolet exposure. Contrary to that, ATOM 2, yes, probably that's how we are today practicing. And although the effect is pretty much similar what the ATOM 1 has showed, but there are greater rebound with higher concentrations, and that's the most important major limitation, that was lack of placebo control, which was being taken care in a LAMP study, where they do have looked at those the different subgroups, including the placebo, and the protocol or inclusion and exclusion criteria, they were more or less similar to that of the ATOM 2. So if you look at, I think all eye drops reduce myopia progression. However, 0.05% atropine was most effective amongst those different concentrations. So I think what we can take conclusion from LAMP study is, I think all drops they do work, all concentrations were very well tolerated. However, 0.05% atropine was the most effective, and that's how we are looking for, especially in India, we are looking for this concentration. So do we still have few unanswered questions? Yes. What's efficacy in long-term follow-up? Rebound phenomenon is of concern even in the 0.05%. Also the efficacy on restarting, how in case of rebound phenomenon. So how does actually this higher concentration do work when there is a rebound and you restart it? Today, do we have the answers to many questions like yes, which is the recommendation for the pharmacological agent? Yes, we do have with different concentrations. What are the indications? I think we can give these drops to children between 5 to 14 years. Simple myopia, axial myopia for sure. Increase of myopia with this rate per year. Where does it does not work? I think the pathological myopia, ROP, or the lasered ROP children's. How long to continue the treatment? At least not less than 2 years. How much should be the follow-up? At every 6 months. When to stop the therapy? Age more than 14 years or no progression for at least 2 years. And when not to stop? If the progression has not reduced by 50% of the baseline or initial progression, then you need to continue it another 1 year. How to deal with the non-responders, either at a higher concentration or you can choose the adding on as a combination therapy. So let's move on to this particular case where this particular child presented at the age of 4 years. His mother had been like high myopic. It was in April 2016. So you can understand that there was a high myopia with very high axial length. So on a systematic workup, you would find that I started this child on the 0.01% HS dose, and despite that there was increased axial length and refractive error. So we subjected this child on follow-up to our the myopia clinic with very standard protocol, and where we have looked into the detailed history, how's the sleeping habits, how the outdoor activities, taking care into all the systematic workup. Then this particular child, you see, from 2019 to July 2023, it was, despite on OD dose, it was progressing. On shifting on to the BD dose, it has shown a slowing down of the progression. Another case, 6-year-old at presentation, mother and father moderate myopes, a very moderate myopia. You can see here the refractive error, and started on atropine HS in 2018. Early age at presentation, and both parents had a myopia. Probably that was the reason at that time, I used to choose to consider for atropine. And you can see that HS dose has helped to stabilize, although there was a sudden increase in the axial length, the post-COVID era, where we need to shift the patient on, the BD dose. This is another patient. I want to bring your attention that whenever there is an anisometropia or anisometropic amblyopia, we do have a tendency to patch these children, and the eye with the low myopic refraction, that eye has shown a tendency of increasing the myopia progression. So we don't know, does the patching is the culprit or other mechanisms where the low myopic eye is competing with the another one is the question probably that I would put to the panelist here. And last but not the least, can always combine with other optical therapies for non-responders. So we do have a pretty much evidence in our hand where we can always choose to combine it with a very stable outcome, as far as the myopia progression is concerned. So this is the one of our in-house, the experience shared by Dr. Jethani et al., where 8 out of 10 patients showed a reduction in progression when he used the combined approach for 12 months. So I think we are looking for atropine 0.05 commercially available in India. Already there is a lot of things going at DCGI to get the approval for this drop. And I think Rohit Saxena and group has published the effect of 0.05, and probably we are ready to actually get drop into and see how does it works in our population. So with this, I would like to conclude that I think this is well-proven treatment, relatively cheaper, easy to use, easily available, and almost no side effects. And I think if you don't have, probably, the BD dose do work, being its effect is concentration dependent, and it can be combined with other optical therapies in non-responders. Thank you very much.
Thank you, Vivek. Great talk. And are there any questions from the floor? And, yeah, please.
Yeah, please.
Come up to the microphone, please.
Very nice talk. I'm just wondering, can we use it as a preventive, like when the parents approach you for their young children and they say that we don't want our children to become myopic. So is it possible that we can say, okay, your child vision is 6969 at the age of 5 years, and I'll start that child on low dose atropine, predicting that that child would not develop myopia?
Yeah, I think this is a very important question you raise. But I would say, until and unless we label that the myopia is progressive, it is not prudent to treat this patient as a prophylactic. We do have other modes, right? If there are risk factors like the pre-myopia, those who have the low hyperopia, parental history, right, the younger age. So we can have the lifestyle modification rather than using the pharmacological.
But you don't have any study on that, because I was going through one of the papers from Japan and they were talking about prophylactic use of low dose atropine.
Dr. Rohit is here. Dr. Rohit, you want to add something? I mean, I don't do practice.
You don't do prophylactic
I don't do it.
atropine.
In fact, it is counterproductive, otherwise the people would start using it without a solid indication.
No,
I think
I think Dr. Vivek is saying absolutely appropriately. There are two reasons why we want to document progression. One is, of course, to treat progression and not treat myopia. The management of myopia is refractive correction. The management of progressive myopia is all these interventions we're talking about. So we need to know. Secondly, we need to know the rate at which a child is progressing, because now we have a lot of options. So we need to know whether our intervention is impacting it or not. So we need to have a baseline of progression, even if at all possible, of a 6-month follow-up. So we know the amount the child is progressing and accordingly intervene. And that's going to make a change. And of course, pre-myopia is being discussed. There are studies. In fact, in East Asia, we now already have intervention of low-dose atropine on pre-myopic children. I would say that, I mean, this is absolutely my take, that the Indian population and maybe the Caucasian also are a relatively low progressor population. So where we could, at a start, plan for the evaluating the impact of lifestyle modification as a first intervention tool before we think in terms of pharmacological intervention. And I think all races, depending upon the rate at which they are progressing and the impact of interventions, have to probably evolve an intervention strategy for them. But yeah, it is being talked of, but you need to take a call when you look at your child individually.
I suppose there won't be any harm even if you try it as a prophylactic. Because sometimes the parents, now the educated parents, with so much of research going on,
I'm sorry to say, but absence of proof is not proof of absence. I'm giving a drop. I don't know in real terms how it's acting. I don't know where it is acting. I believe it's acting on some receptors which are in the choroid. And I don't know, they're not there for my atropine to, have an effect. They're there for some purpose. And we are blocking them in a 6-7-year-old child who has another 70 years to go. I don't know what's going to happen to them. So I would say that, I don't, just because I believe there are not side effects that are apparent upfront, I should not make it standard of therapy. As I mentioned, it's very, very important that we have a discussion with the parents and individualize the treatment. The parents must know that, our understanding of myopia itself, what to talk of interventions to prevent progression, is very, superficial at best. So again, I would be cautious. I would be always cautious to take any treatment to a child when I'm not very sure what it's going to do in the long term. But again, individualized treatment.
Yes,
I think I
we
just
can
want
take
to
your
add one
question,
more
please.
thing, and that is, in India, when we start pushing our children to start reading at the age of 3 years, they should be asked to start reading at the age of 5 and later, and that would slow the progress of myopia. Thank you.
Thank you. Yeah, quick.
Please come
Yeah,
on to
please,
the
please,
speaker,
yeah.
please. Yeah, Mike.
I just want to add one point. We are looking for the axial elongation. We always need to match with the age norms, and then we need to treat, because looking at the child, they will progress. Their height is progressing. Their everything is progressing. They will progress. So there should be an age match progression. And on the top, we need to decide that there is an actual progression or because of the age match progression, and then we should need to treat. And there is another, your first case, do you have any systemic like connective tissue disorder? Because most of the time, very high myopia in the early phase of life, they are associated with the increased myopia, but they won't progress over the period of time, and they are very much stable. So we should not treat at that cases. So we need to look for any connective tissue disorder.
Yeah, I think that particular child didn't had any connective tissue disorder, but it was kind of the simple high pathological myopia. But always, yes, that's how we.
Yeah.
Yeah, but again, if you see the literature, that cutoff for treating with the myopia is more and more increasing. Like even more than 16 and 18 years. So.
Tempted to treat the progression very early stage of the life without knowing what are the causes of myopia. That's another story there.
Yeah, actually, I had the same similar thought. In addition to connective tissue diseases, retinitis pigmentosa is one major cause of secondary myopia. And in those cases with retinitis pigmentosa genes, in promoting outdoor activities or some kinds of light therapies, maybe could be harm. So I think maybe excluding them is stickler, yes.
Very high myopia, nothing else will be there in so early stage of life, and those very careful.
Okay.
Yeah, maybe I can comment on the use of prophylaxis low-dose atropine. Actually, the LAMP2 study performed by my colleague Jason Yam, it's been performed, and it can actually reduce the incidence of myopia in these non-myopic patients. So low-dose atropine, 0.5 milligram, 0.5%. After 2 years of use, it's about 23%. But if you are using just placebo arm, it's 53%. So you can reduce it more than by half of the incidence. So if in some patients, if you high-risk patients with like highly myopic parents, genetic makeup, and in Hong Kong, the dense environments, I think, so it might not reflect in other population in India or Caucasian, but definitely in Asia, in East Asia at least, I think it's definitely something that's worthwhile to think about.
Thank you very much. And so I'd like to introduce our next speaker, who is, yes.
Good afternoon. Since myopia progression, the axial length progression tends to be seasonal. And in the West countries where we have winters, for example, the exposure of the sun is not much. So my question is from diagnosis and treatment aspect. So do we measure the axial length every 6 months or on an annual basis?
Yeah,
when we are diagnosing and treating a patient?
Yes, so we have our AIOC consensus guideline and WSPOS. So we do every 6 months.
Yeah, thank you so much. So the next speaker is our dear friend, Timothy Lai from Hong Kong. He's going to talk about management of myopic CNV.
Thank you very much, Kyoko, and I'd like to thank all the organizing committee for inviting me to give this lecture. So I'm going to talk about myopic CNV, which is, of course, a very important complication of pathologic myopia. So these actually occur in roughly about 10% of eyes with high myopia, and it's the most common cause of CNV under the age of 50 years. It's the second most common cause of CNV after AMD, and the incidence is around 10% with a follow of 10 years. So you can see from Professor Onomitsui's group study, a natural history of these patients is not that good. So initially, around 29% had a vision of worse than 2200, but with without any treatment, 5 to 10 years down the road, 90% will have a vision of worse than 2200. So in the white paper we published earlier, so you can see how it progresses from high myopia down to pathologic myopia. You get progressive choroidal thinning and macular atrophy, and then you can get these lacunar cracks, patchy atrophy, and then myopic CNV formation. So how to manage these cases? Firstly is to confirm the diagnosis and choose the available anti-VEGF agents. So we have ranibizumab, aflibercept, and convercept in China, and off-label use of drugs. Also decide on the dosing regimen. PRN mostly, sometimes you might consider using loading dose, but rarely we use treat and extend. For an investigation, we have many investigations, so very standard tests including biomicroscopy, fluorescein angiography, OCT, additional tests if you have them, OCTA, ICG angiography, and fundus autofluorescence. So it's very important for us to differentiate myopic CMV from other existing diseases that can mimic the degenerative changes, for example, myopic foveal schisis, macular hole, dome-shaped macular, staphyloma, as well as other causes of CNV like neovascular AMD, punctate inner keratopathy, and idiopathic CNV. So these are just some OCT you've heard our excellent talks previously, myopic foveal schisis, myopic macular hole. And what's the most commonly used diagnostic utility is still the fluorescein angiography. So in all the randomized control trial, you need the FA to confirm the myopic CNV. So basically, these CNV appear as a well-defined hyperfluorescence in the early phase and leak in the latest stage. It's used to determining CNV location as well. Spectral domain OCT, of course, is very now frequently used because it's non-invasive, and you can look at the qualitative and quantitative assessment of the retinal fluid and measure the subretinal and extracellular fluid. EDI imaging is also useful to document the choroidal thickness. So how do FA and SDOCT compare? So in this study performed in France, you can see in general, CNV can show up on FA in about 82%, OCT about 48%. So you might, about 16%, you needed both to diagnose it, CNV. Here's another case. Sometimes you can get coexisting features. This patient also a myopic traction maculopathy together with a CNV lesion. So OCTA now is available in many places. It actually has been introduced into the management in the diagnosis of myopic CMV. So you can actually, if you have OCTA, if it's available, if it's positive, then you can actually start the treatment without doing the FA. But if sometimes it's non-conclusive, so you still need the FA sometimes. Of course, we now have AI with deep learning approach, so very good study performed by, again, Professor Onomotsui's group. You can see they look at the fundus photo and see how you can actually detect the various changes in myopia. And for myopic CMV, they still get a very good result by just looking at the fundus photo, get an AUC of about 0.88. More recently, video OCT angiography, so with the color mode, you can actually see that the Italian group, they actually use this OCTA corresponding quite well to the FA changes. And by using this method, you can see very good diagnostic, static OCT about 82% in the active CNV, but with the video color graded, you can see increased to about 97%. So in total, the colored OCTA, it's actually quite useful. Now let's look at treatment. So of course, the standard of care now is to use anti-VEGF therapy because you get elevated of VEGF inside the eye with these myopic CNV. The first large study is the RADIANT study, which looked at the use of ranibizumab either stabilizing the vision or disease activity versus ferdiporfin PDT as the control group. So it's a one-year study initially, and at the primary endpoint, you can see that ranibizumab treatment, either based on visual stabilization or disease activity, they both improve the vision substantially, and there's no difference. So nowadays, we're using it one injection and then PRN. The patient at 1 year sustained visual gain, and patients on PDT initially, and then they were having ranibizumab treatment. You can see they still also had visual acuity gain. In terms of subgroup analysis, we looked at various subgroups in terms of baseline vision, myopia, severity, axial length, baseline lesion. In all subgroups, it showed that ranibizumab is beneficial. But bear in mind that if you have larger lesion size, you needed more treatment. So median about like 5 for the largest subgroup. So in patients with larger myopic CME, I will warn them that you need more injections. So sometimes I even give loading doses for them. Brilliance is just another study also using ranibizumab conducted in Asia for the registration of ranibizumab for myopic CME in China. Again, very consistent result with compared with Radiance, very good visual acuity gain as well. And the long-term result, we looked at the post-Radiance study. After the Radiance, we followed these patients for another 3 years. You can see over the long term, they also had very good vision gain, not like those with neovascular AMD, for example, those who might have a decline in vision. And those without further treatment gained further. And some of them had recurrences, again, very good result with the retreatment. For other drugs, so you have aflibercept, which is based on the MIRROR study. Patients randomized to either aflibercept or a sham for the first 6 months, and then they were able to switch to aflibercept at 24 weeks. Again, very robust result, anti-VEGF with aflibercept, 2 milligrams, worked very well for these patients. But you can see with these patients were delayed for 6 months for treatment, the visual outcome is not that good. So you can see almost 10 letters of change. So that's why we need to treat these patients early with anti-VEGF agents. In China, they have the SHINY study, which used Combricept. Here it's a bit different. They use loading doses. So loading doses, and then patients were in sham for about 3 months. And then, so here you can get very good visual acuity gain. Mean injection a bit higher compared with other study because they had loading doses. So Combricept is only approved for myopic CME in China. Very good anatomical response as well. So the guidelines based on all these findings that we've got very good level 1 evidence in the use of anti-VEGF therapy for our patients as a first-line treatment. In the real world, how does it work? So in IRIS registry of the AO, you can see that patients who actually had anti-VEGF treatment, they gained about 2 lines of vision. Compared with those who were only observed, they lost a little bit or has stable vision. And majority of cases, you can see very low number of injections. Let's look at some of the newer studies. So if you look at this study, again, Professor Onomitsu's group, dilated choroidal veins might have some role in these myopic CNV recurrences. And if they actually have the dilated choroidal vein, you can see a much higher chance of the first recurrence. So look for these cases and maybe consider monitoring these patients more frequently. More recently, there were some studies also looking at patients without the pathologic myopia features, but they still have high myopia. So here, the patients with pathologic myopia features. Down below are those with just high myopia, but they do not fulfill those criteria of the META-PM study group. And they found that these patients actually had the patient with high myopia, they're a bit older, and they would actually require more injections compared with the typical myopic CME patients. And in terms of the long-term outcomes, the long-term outcomes for these 2 groups were actually quite similar. And you can use the treatment regardless of aflibercept or ranibizumab. Finally, we are now conducting the POYANG study, which actually it's in the use of faricimab, due inhibition of Ang2 as well as VEGF, and recruitment started in February last year, and hopefully we can share with you the results sometime in the future meeting. So just to conclude, based on the currently available evidence, all the anti-VEGF agents appear to be effective for myopic CMV. Majority of eyes only had a low number of injections, and further studies will be useful to determine the prognostic factor and new therapy for myopic CMV. Thank you very much, and hope to see you in Hong Kong for the next APAO. Thank you.
Thank you, Timothy, for a great talk. Any questions from the floor? Yeah, Timothy, I'm still have some difficulties differentiating from myopic CNV and peak CNV. Yeah, and this is important because for peak CNV, maybe we may need to consider steroid or immune suppressive agents. So how could we differentiate these two more efficiently?
Yeah, thank you, Kyoko. Very important question, and it's not easy sometimes, but I would look for other features of PIC. For example, previous PIC scars, those tiny dots of the choroiditis, and usually myopic CME, you can also get more clear cracks as well. I think that's another differentiating feature which might be useful. And of course, the severity of myopia, if you have like minus maybe 10 or 15, it's more likely to be a myopic CME than a PIC lesion. But a very good question, thank you.
I see. Thank you so much. Yes, please.
It's okay, yeah.
Thanks, Tim, for a great summary for myopic CNV. May I know how far out of the central zone would you consider treatment, and which one we will actually observe if, let's say, it's 500 micron or 1,000 micron from the foveal center?
Well, if it's over 500 microns, maybe you don't need to just observe it closely. But if it's a large lesion, I would still treat it because it might progress. But usually they don't come in. So it's mainly the subfoveal and juxtafoveal patients that are symptomatic. They come in to see us. So we rarely see the extrafoveal lesions.
Thank you.
Thank you.
Yeah, Tomo, please.
Thank you for. Thank you for a great talk. So my question is about as you show, myopic neovascularization can occur in the cases with myopic traction maculopathy, and the previous report said that the regression of myopic neovascularization can worsen the myopic traction maculopathy condition. So in those cases, like the urgent cases, like foveal retinal detachment or macular hole cases, so what should we do first?
Oh, very good question. I don't think we've got a very good clinical study on that, but I would definitely treat the myopic CNV first, just give an injection, and then maybe arrange a surgery for that in another like 2-3 weeks, something like that, if there's a foveal detachment, because I don't want it to progress to a macular hole.
Yeah, just please.
Choroidal macular neovascularization, also in myopia, can be followed by a subretinal proliferation of RPE cells leading to the scar. Would it make sense to think about potential therapies preventing that scar formation?
Yes, definitely. Unfortunately, we don't have a very good effective drug at the moment. Previous trials have failed. For example, for Vista using a PDGF, it didn't work. So I think you have studied on the like FGF and all these. Don't want to say it. Yeah. Okay. So yeah.
Okay. Thank you very much,
Thank
Timothy.
you.
Yes, I'd like to introduce again my dear friend, who is Dr. Xu-En Lee from Singapore. She is going to talk about surgical interventions for retinal complications of high myopia.
Thank you very much, Kyoko, and thank you for having me as part of the panel today in Delhi. It's a great pleasure to be here. I'm often asked tips and tricks in dealing with surgery, especially in highly myopic eyes, and I thought I'd do a quick summary of considerations in these eyes. So we know these are the main issues we look at in high myopia, and what we really focused on is in the macula. They do get rheumatogenic retinal detachments, but we're not going to really talk about that today. And Dr. Takahashi gave a very nice summary on myopic traction maculopathy. So I think it is an intellectual exercise significantly when it comes to making plans on how to manage a patient with myopic traction maculopathy. It's not like a situation of, okay, the patient's got an acute rheumatogenic retinal detachment, let's go save this guy's vision. In myopic traction maculopathy, you really need to decide, is really surgery indicated or not? Not all MTMs require surgical intervention. And then timing, when should the surgery be done? How do you plan for it? What do you consider when you want to do the surgery? And then what about the post-op? And you need to be a lot more careful in these pathologic myopes than in other eyes. The main indication, of course, would be deterioration in vision. There would be some blurring of vision. Sometimes they don't really give you a very good history because of the high myopia, some level of amblyopia. But sometimes you get a central scotoma. If you have the luxury of having this patient with you for some time, there is the history, a natural progression. You can track the patients. A lot of us, I think, have patients who stay with us for many years, and you can actually track how their maculas change over time, and whether or not they have developed complications like a foveal detachment or a hole in the macula, or with macular hole detachments. And the aim of surgery really is to relieve traction. And this traction, you need to be able to relieve it in all directions, anterior, posterior, tangential, whether it's in the macula, whether it's in the peripheral retina, and you want to try as much as possible to restore the anatomy. There's no real firm recommendation for the timing. Generally, these eyes are slowly progressive. So in like that question that Dr. Takahashi asked Tim earlier, I would treat the CNV and be very aggressive with the CNV first, and I wouldn't rush with the surgery for the myopic traction maculopathy. You can develop also macular holes after treatment of a myopic CNV. It's nicely scarred down. Then when it's nicely quiet, you can still go in and intervene and repair the hole after that. Because these are usually slowly progressive. Even the myopic detachments don't progress like a rhegmatogenous detachment in the periphery. If it progresses quickly, then I would hunt for a peripheral break, and not just on a macular pathology, right? And if you do start to pick up some form of progression on the OCT, then it is probably wiser to intervene earlier rather than delay it, because we all know it's much, much harder to repair a myopic macular hole than to repair a lamellar hole or MTM. So I like to study the OCT significantly pre-operatively, and if we all had the luxury of Kyoko's wide field OCTs, that would be great. But sometimes you need to try and play tricks a bit and get the patients to look left and right and try to understand the vitreoretinal interface as much as possible. You want to know how many layers you're going to peel. You want to know where are points of traction that you want to focus on. You want to know also where are the points that you can initiate a peel, because these myopic retinas are super fragile, super thin, and if you can find a point where it's the membrane is thickened, is elevated, that's going to be an easy pickup point that you want to be able to see. I like this paper that was published by Murasi some time back. They talk about sukimas. If you look at the OCTs and you see these nice ERMs, there are little points of attachments. If there are multiple little points of attachments with little gaps between the ERM or the ILM and the retina underneath, it's going to be an easy peel. And so you can give it to the fellow and you don't have to worry about it. But I mean, most of us would not give a path-myopic eye to a fellow. But if you have no sukima and it's a very adherent peel, then you're going to know that I'm going to have to actually be a bit more difficult in initiating and elevating the peel, and it's going to require a bit more action to peel completely. And in some of those, you might end up shredding the ERM as you peel rather than peel it as a one nice sheet. You want to look at the intraretinal changes pre-op, because that helps with prognostication. If there's significant drill, it's not that big a deal, but if there's significant outer retinal disruption with the EZ line lost photoreceptor disruption, then even if you can restore the look of the architecture, the function may not improve significantly. And then, like I said earlier, the patient might have previous CNVs, might have previous lacquer cracks that could then also have impact on the visual prognosis. So this is important to tell the patients and how much they can recover. Other tests, I always like to do axial length measurements for all these eyes, because it helps me decide surgery, what instruments, what gauge to use, and how I'm going to peel. If you have a deep posterior staphyloma, you want to be able to peel carefully without hitting the sides of the posterior staphyloma and causing intraoperative hemorrhage and scars. B-scan ultrasounds will then help to show the configuration of the staphyloma, and so if you can do that, that helps. UBM is helpful because in these really highly myopic eyes, you might be able to see where, further back the ora serrata is, and you want to try to place your pots as far back as possible so that you have greater access. If you don't have a UBM, the other way is that before you put in your right-hand pot, you put in the two other pots first, and you can indent to look at the ora and then try and go as far back as possible. A lot of these highly myopic eyes have got early cataracts. It's a discussion and a consideration whether you want to deal with it at the same time, before or after. It helps with surgical visualization if you do it at the same time. And then, of course, tamponade. Generally speaking, if there's no hole, I wouldn't require a tamponade. So axial length is an issue. Thin scleras, so you want to be careful that even if you use a 25 gauge instrument, the scleras are very thin. You may not be able to self-seal. Don't hesitate to pass a suture through the ports if necessary. Poor contrast, that's why we have the help of dyes, whether you use triamcinolone, indocyanine green, or one of the blues. You need to be able to remove all the adherent posterior cortical vitreous before you get to the membranes. And knowing the axial length will tell us whether we're going to do 23 or 25 gauge. Most of us would not, I think, perform 27 gauge surgery on these pathologic myopes because you're not going to be able to reach it, and the instruments might still be a bit too soft to be able to peel off really adherent membranes. So, and I think in highly myopic eyes, I don't think you should worry about not being able to see. If you need to double stain, triple stain, you may have to stain it to see the posterior cortical vitreous, stain it to peel the ERM. Maybe it comes off together with the ILM. If it doesn't, you have to, maybe you want to stain it again to show the ILM and peel it off. And then you maybe want to stain it again, especially if you're not so experienced, to check that you have really peeled off everything. So don't worry, that bit of brilliant blue or membrane blue dual is more than enough to cover the entire surgery. And also because of the fragility of the retina, be very careful how you shoot in the dye. Because if you're too zealous with the shooting, you can actually convert a lamellar hole or into a hole, or a super fine, thin fovea that is detached into a hole from the jet spray. And try as much as possible to peel on the retina surface without lifting up. So you can see that this patient, we were able to track from 2011 all the way to 2024. And as the eye tries to undergo PVD, you can see that it doesn't separate properly. And as a result, it causes vitreoretinal traction and significant retinoschisis. And within a week, you can see that there's significant relief of that traction, and the anatomy gradually takes time to recover. And once there's anatomical restoration, vision can improve. You want to enhance your view. You want to be able to visualize very well, increase the magnification, be careful with the lighting, but you want to peel, see on the surface of the retina. Don't lift it, because if you lift it, you can also tear the retina, especially if it's very adherent. So try to peel on the surface, create a nice flap if you can, and do a nice rhexis. This is a patient, like I said, if you have a very thin fovea because of detachment, if you shoot dye too energetically at the fovea, you could pop a hole. But in this case, what I like to do is I like to look at the extent of the macular detachment and then plot the peel, the extent of the peel. Because you know that if you don't, you need to peel enough of the ILM to relieve the traction. If you don't peel enough, then you may not be able to do that. So you need to study these quite well. And I like to show this long follow-up because it takes time for these eyes to recover. That subretinal fluid, there's still a little bit at 6 months and 9 months. Then, so very often these patients are going to be seeing you very frequently in the first year after surgery. Like what Dr. Takahashi showed earlier, nowadays there's foveal sparing peel. It's quite common to have LHEP associated with these eyes, and again, so you want to. What I usually do is I peel that off first, and I stain again, and I peel the ILM, and I leave it all attached at the fovea. rather than peel the whole thing off. So it's a double-edged sword, how far you peel, how much you peel, because you want to relieve traction, but you want to also minimize the downfall effect. So like what Professor Kyoko Ono said, you want to try to tailor your surgery to each individual eye. This is another eye. This is 31.3 millimeters long, only eye, 14 diopters, which I followed for several years from 2018 when we treated the patient with myopic CNV. Well, actually, it's 2015 where there was a detachment and then was good vision recovered to 6.9, then was complicated by a CNV. Quietly after treatment with ranibizumab, but several years later, you can see that it developed that membrane and then that foveal cyst, so we had no choice but to do surgery because the patient's only eye. So in this case, because of the axial length of 31.5, if you have a reusable forceps, the reusable forceps, you're able to reach it. If you use the disposables, most of the time you won't be able to reach a 31.5 millimeter eye. So based on the OCT findings, you can try to figure out where the fovea is and try to figure out the extent of the peel. And then you restain it to double check. Because these eyes you can't really see for 100% sure. Because of the really lack of contrast. Okay, and then you see within a week there's recovery and the foveal cyst is gone. If you have the luxury of intraoperative OCT, that's really helpful. You can see pre-op and at the end of surgery, at the start of the surgery and the end of the surgery. This eye was 33.2 millimeters, and at the end I had to convert the right-hand port to a 23 gauge to be able to peel it. Otherwise, I was not able to reach. So you can see me converting it into a larger gauge. There's one last thing that I wanted to say about these eyes. We can restore the anatomy, but sometimes we lose the eye to glaucoma. So this patient, I got the patient good anatomy, okay, at 3 months, but the patient didn't recover any vision because he developed open-angle glaucoma, which is not uncommon in these highly myopic eyes. So I would say that I wouldn't discharge any of these patients even after I've restored their anatomy, because they have normal tension glaucoma and you have to just keep monitoring them. Thank you very much.
Thank you, Xu-En, for a great talk. Any questions from the floor? Yeah, glaucoma is coexistence of glaucoma is a worrisome lesion. So how do you exclude glaucoma, diagnose glaucoma before surgery, or?
Usually not. Usually, because of the existing retinal pathology, the visual fields are a bit tricky to interpret. But I think if you have regular, because the patients come back regularly, you can do the RNFL glaucoma scans, you can do baseline, and then you can follow up, and you actually rather track them rather than rely on just the visual fields.
Okay, thank you so much. Tomonari?
Oh, thank you for a great talk. So I have one simple question. How do you deal with epiretinal proliferation? So I mean, so for normal inner laminar macular hole cases, embedding the epiretinal proliferation is effective than normal peeling. So how do you treat in the myopic traction maculopathy cases?
I don't like to embed, because I find that I tried it before, but I find that it creates this space-occupying lesion sometimes that actually prevents a proper healing of the cellular integrity. So I actually leave it as a cuff at the fovea. So I peel right up to the foveal edge and I trim it down, but I leave a cuff there so that it acts as a bridge for recovery rather than I stuff it in.
So in those situations, do you do the tamponade or something?
No.
No.
Yeah. So thank you so much. Vivek, please.
Yes, so I think we are left with 2 talks. So both of these talks, they are actually pre-recorded. So I think looking at the time, we will be able to take one of them. So please run the talk by Dr. P. Lee. He is from China, and he has recorded his talk with title Longitudinal Changes of Multimodal Biometrics in High Myopia. So please run that particular talk.
Li from Zhongshan Ophthalmic Center, China. I am going to share with you our findings on longitudinal changes of multimodal biometrics in high myopia. I have no conflict of interest. The prevalence of high myopia is on a significant rise globally. High myopia escalates the risk of various ocular complications, including myopic maculopathy, retinal detachment, and notably glaucoma. The prevalence of glaucomatous optic neuropathy in highly myopic eyes can reach up to 27.2%, underscoring the critical need for vigilant screening and management in this population. Currently, the diagnosis of myopic glaucoma is fraught with challenges. Firstly, imaging-based diagnoses are complicated by myopic fundus changes. High myopia induces specific structural changes in the eye that can mimic or obscure glaucomatous damage, complicating the interpretation of OCT scans and often leading to misdiagnoses. While glaucoma and high myopia each have their distinct types of visual field defects, both conditions can present with overlapping visual field defects, such as paracentral defects and nasal steps. This overlap furtherly complicates the diagnostic process, necessitating advanced diagnostic approaches. According to cross-sectional studies, the structural and functional abnormalities of glaucomatous optic neuropathy in cases of high myopia are not readily apparent. Therefore, this necessitates longitudinal studies to gain a clearer understanding. We first explored the longitudinal changes in OCT metrics of high myopia and highly myopic glaucoma, HMG. The study was divided into groups: high myopia, open-angle glaucoma, OAG, and HMG. We observed temporal PR-NFL thinning occurred more rapidly in HMG compared to OAG. In HMG, PR-NFL thinning was more pronounced in the inferior and temporal sectors, and MGC-IPL thinning was more pronounced in the infranasal sector. Based on the mean deviation values from VF, we further categorized the HMG and OAG groups into different stages for analysis, and the results corresponded with previous findings. We discovered that temporal thinning of the PR-NFL was more rapid in mild HMG compared to mild OAG, with no significant differences observed at moderate or advanced stages. Additionally, thinning of the inferior MGC-IPL was more rapid in moderate to advanced HMG compared to moderate to advanced OAG, with no significant differences noted at the mild stage. The discovery of longitudinal changes in OCT metrics, particularly the rapid thinning of the temporal PR-NFL in HMG, may provide crucial biomarkers for the identification of HMG. In addition to OCT, longitudinal studies of OCTA parameters have revealed distinct microvascular abnormalities between high myopia and HMG. Our follow-up of primary open-angle glaucoma, POAG, with and without high myopia, showed that high myopia with POAG exhibited a faster reduction in capillary density in the deep capillary plexus compared to POAG eyes alone. Furthermore, the density in the deep capillary plexus decreased more rapidly when the baseline capillary density was low. In addition to fundus imaging, axial length is also a critical follow-up observation indicator for high myopia. Evidence from Mendelian studies, experimental research, and clinical cross-sectional data indicates that IOP-lowering medications may be capable of delaying the progression of myopia and axial length. Longitudinal studies of axial length in eyes with high myopia have revealed similar findings. Research has shown that axial length continues to increase in adults with high myopia. and that rapid axial elongation is associated with factors such as age, gender, and myopic maculopathy. Furthermore, the topical use of anti-glaucoma medications may be useful in reducing ongoing axial elongation. To further explore and validate whether IOP-lowering medications can delay the progression of axial length, we have designed a randomized trial, the PHM study. This trial recruits highly myopic participants with progressive axial elongation. Participants are randomly assigned to either the intervention group, where they use Xalacom nightly, or to the control group, which does not receive medication. We have conducted a preliminary analysis of participants who have completed the one-year follow-up, including 33 in the intervention group and 27 in the control group. The results indicate that the difference in the rate of axial elongation before and after enrollment was significantly slower in the intervention group compared to the control group. Functional changes are also critically important for distinguishing glaucomatous optic neuropathy in high myopia. Therefore, our team has developed a novel classification system for visual field defects in non-pathologic high myopia. This system encompasses 4 major categories: normal, HM-related, glaucoma-related, and combined. Within these, there are 10 subcategories of visual field defects. This classification aims to enhance our diagnostic accuracy and provide a clearer understanding of the interaction between myopia and glaucomatous changes. Based on our novel visual field classification system for non-pathologic high myopia, we have identified that the 3 most common visual field patterns are normal, enlarged blind spot, and non-specific defect. Our research further indicates that older age and longer axial length are risk factors for glaucoma-like defects in highly myopic eyes. Notably, 1/3 of the highly myopic eyes with glaucoma-like defects eventually develop into glaucoma. This finding underscores the importance of regular and comprehensive visual field assessments in managing highly myopic patients, particularly those at greater risk due to older age and longer axial length. We are currently conducting a longitudinal study designed to explore the progression rates and characteristics of various visual field defects within our novel classification system for non-pathologic high myopia. By analyzing the longitudinal data, we hope to identify specific patterns of progression that may indicate an increased risk of developing glaucoma and providing valuable insights into the early diagnosis of glaucomatous optic neuropathy in high myopia. In summary, diagnosing glaucoma in high myopia is challenging due to the complexities revealed by cross-sectional studies requiring precise individual assessments. Longitudinal studies are crucial as they provide deeper insights into the progression of glaucoma and myopic changes. Preliminary results from our trials suggest that IOP-lowering medications may slow myopia progression, but further data from ongoing studies are needed to confirm this potential. Thanks for all the members in the glaucoma suspect and high myopia study group. That's all. Thank you. Hi everyone, I'm Fei Li from Zhongshan Ophthalmic Center, China. I am going to share with you our findings on longitudinal change.
Thank you very much. It is a time, and so we are going to conclude this session. Thank you very much for all speakers and moderators and attending this session. Thank you.